Now, as you've started to understand hemodynamics, let's talk about shock and how these hemodynamics are going to relate to the process of shock in a patient. So, what is the big deal with shock? Like just the word shock, it sounds like you should be reacting, right? Well, the big deal with shock is that there is decreased blood flow. And decreased blood flow means decreased tissue perfusion, which means my tissues and my other organs cannot function the way that they're supposed to. The demand that my body has for oxygen outweighs the supply. And so there's a mismatch of how much oxygen I have available versus how much that I need in that current moment. And there's three main types that you're going to start out learning about, and that's going to be cardiogenic, hypovolemic, and septic. And we're going to break each of those down individually. Something to keep in mind when talking about shock is all types of shock have low blood pressure and low cardiac output. So in all of these, there's not going to be a type of shock that we're like, oh, the cardiac output's high in this one, or the blood pressure is high in this one. No, a shock by definition is that my body has exhausted all of its normal mechanisms for compensating for a problem. Um, and what happens at the end of it is that my heart's not pumping the way that it's supposed to. I don't have enough volume that I need, or something has overwhelmed my body system to the point that I have like usually a widespread issue where I cannot get the perfusion to the tissues I need. Shock is all about tissue perfusion, and that because when we don't get that, we end up getting tissue death and organ death as well. All the happy things. So let's talk a little bit about the stages of shock. So there's three stages. There's the compensatory stage, which is, the body's pretty much saying, I need some help. It's starting to call for help. And so this is sympathetic nervous system, the fight or flight gets activated and comes in and helps. The RAS or the renin angiotensin aldosterone system also gets activated and comes in and helps. There's also like what happens is, of course, then like, all these things are coming in and helping. And a lot of their efforts help at first. It's not that they completely make things worse. But what happens in shock is that you then move into the progressive stage where, pretty much all of your helpers are exhausted. Your sympathetic nervous system is like, all right, I'm only supposed to be here in emergencies, and you've been in an emergency for way too long now. The RAS is exhausting all of its resources, or it's just making things worse. And you start to see changes in mental status and fluid shifts start to occur, and that's where you start to see a lot of that decreased signs of decreased tissue perfusion, and they can start going into multi-organ failure. And refractory is, the last stage where effectively there's a lot worse fluid shifts. There's a massive vasodilation, which again, you always think vasodilation is good, but blood pools, everything's open. And so, fluid spreads from the where it's supposed to be in the blood out to the tissues. And there's just no blood flow or perfusion. There's profound low blood pressure, regardless of interventions, and lack of oxygenation throughout their entire body. Da, da, da. Sounds really sad. So let's talk down about these types of shock. So, like I mentioned, there's three main types that you need to know in this beginning phase. You'll learn about some other types in other sections. Um, but effectively, cardiogenic shock is the first one we're going to talk about. And anytime you're thinking about shock, these three types, you want to think about, what is the problem? And in cardiogenic shock, the problem is the heart is not pumping the way that it's supposed to. And the most of the time, this happens because there's some sort of heart problem going on, like a heart attack, heart failure, cardiomyopathy, damage to the heart muscle, really bad heart infection, etc. And think of anything that can affect the heart's ability to pump or to squeeze, to contract the way that it's supposed to. So the problem here is that they have low cardiac output. They cannot contract or squeeze the way that they're supposed to. And then they have high preload. So they can have high CVP, high PAWP, high PAD. All of these mean the same thing, that there is too much fluid on board. So those are the two things that kind of make this one different. All of these have a low cardiac output, but keep in mind, it's really important to note that this one has low cardiac output because the heart's not squeezing. There's a problem with my pump where it can't squeeze and move forward. And that's really important because that's going to tell me, what do I need? If my heart's not pumping, what do I need? Well, like it says down here, my solution if in cardiogenic shock is to give medications that are going to help my heart to squeeze or pump. So I'm talking about things like dopamine and dobutamine, the positive inotropes. I'm also going to use diuretics to decrease some of that preload, because all that extra fluid adds to the workload on my heart, and it actually makes it harder for it to pump and to get back that strength because it's working so hard because there's so much fluid on board. And then, of course, I want to fix the problem. If the patient's having a heart attack, I want to go in and get them treatment for that. If they're in heart failure, I want to try to manage that. If they have an infection, I want to try to treat the infection. But whatever I can do to support them along that way. There's also hypovolemic shock. And so, hypovolemic shock, just like in the name, it's a loss of blood volume. They could either have lost fluid or blood. So, I mean, they could be bleeding. Maybe they had a trauma or something happen. They could be vomiting or having a lot of diarrhea or something like that. And then they also can be third spacing. So, people that are burns or people that have some like liver and kidney disease where they have a loss of their ability to keep fluid where it's supposed to be, where their fluid starts going out into their tissues and cells, and it's what called third spacing. This also there's volume, but it's not where it's supposed to be. So at the end of the day, they can go into shock over that. And so, sorry, just looking this up real quick. So the main problem here is that they have low preload. Like that's my issue is I don't have enough volume to sustain my body to get that adequate cardiac output. So if my problem is a low preload, then I need fluids or blood. I want to replace whatever's missing. If they're not missing blood, I'm not going to give them blood, but I'm going to give them whatever they're missing. Now, let's say that I give that fluid or that blood and their blood pressure is still low. I may need to use medications like vasopressors to help to give myself some vessel squeeze to help with their blood pressure. And then, of course, I want to fix the problem. If they're bleeding, I want the bleeding to stop. If they're having vomiting or diarrhea, I want to stop that. I want to treat their liver kidney failure if they're third spacing or treat their burns. But as a whole, I want to get to the solution to the problem because I can keep putting fluid and blood in them. But if they're losing it at the same rate that I'm giving it, it's not going to help. So then there's septic shock, and septic shock is all about an infectious process. It's an infection that leads to an inflammation process and leads to a massive vasodilation. Unlike most of the time where when your body's in like kind of a state of like, oh my goodness, I need help, it simulates that fight or flight, which usually vasoconstricts. But in what happens in infection is that your body is like, hey, I need to get all of my guys over here to help fight this infection. So what it does is it pretty much opens the doors to the cells to allow more things in and out, to allow all of those inflammatory mediators to come in and help fight infection. But what the problem with that is when those doors open, then fluid can get in and out. So there ends up being this massive vasodilation to try to fight this infection, but it gets to the point where it's not helpful at all, and there's all these fluid shifts, their blood pressure drops, and they get into the state of shock. So there's a couple different stages here when we talk about septic shock. First, there's SIRS, and for SIRS, you have to have certain criteria. And this, all SIRS tells you is that there's inflammation going somewhere in your body. And so there is, the four, criteria that are most commonly used are temperature, either too high or too low, heart rate too high, breathing too fast, and then a white blood cell count that's either super low or super high. Excuse me. If my patient has at least two of those criteria, they meet the criteria for SIRS or systemic inflammatory response system. In other words, that I have inflammation somewhere in my body. I'm sorry, my cat's being noisy. Then in order to progress from that inflammatory process to shock, what happens next is that I have to have some sort of suspected or confirmed source of infection. Let me get a drink. And so, the key thing there is a lot of times it's going to take a couple days for me to confirm that they have infection. I'm not going to sit there and be like, well, it might be sepsis, but we're going to wait and see what their culture says. If they're showing signs of infection, we're going to go ahead and start treating them like a patient with sepsis. If we suspect that there's infection somewhere. Because even before we get a culture back, if they're showing signs of an infection, like a lot of these inflammatory signs, like an elevated temperature, elevated heart rate, and maybe like I check their urine and their urine looks like there's infection and it's kind of cloudy and yucky, maybe has an odor to it. Maybe they have a wound that looks like it's infected. Maybe they're having respiratory symptoms, like they might have a respiratory infection, whatever it might be. If I'm suspecting there's infection, then if they have those the elevated or low temperature, heart rate elevated, the tachypnea, the white blood cell count that's elevated or too low. If they have that, plus signs of an infection somewhere, like, like I said, smelly urine, a wound that looks like it's having like purulent drainage coming from it, whatever, then that's how we can diagnose sepsis. Um, what happens next is we start treating them for sepsis. We give them fluids and things like that. And that's where we can start to look into septic shock. So if a patient that has sepsis gets fluids and their blood pressure still's low after receiving the fluids, then that's where we kind of classify them as having septic shock. And then what happens next is as we see that progress. And this is, I'm not saying that this happens in every patient, but what can happen is they can go into multi organ dysfunction syndrome or MODS. And that's where at least two organs are failing due to the decreased perfusion that's going on, within their body because of that shock like state. So I'm going to be monitoring their organs for signs of failure. And a lot of the organs that fail first are going to be things like the kidneys and the liver and things like that. So I'm going to be monitoring the function of those organs. And like I mentioned, sepsis always goes back to an infection. So look at this. It starts as an inflammatory process, and then there's this infection, and it leads to this state where even though I'm given things that should help this patient get better, it's still not helping. And then their organs can start failing. And it all starts with an infection and an inflammatory process that leads to some vasodilation. So the problem here is that I have a low volume because remember, everything's vasodilated. So all that fluid that's in my blood gets kind of pulled into my cells. And there's also that vasodilation. So I do not have enough resistance or squeeze in my blood vessels. So if that's my problem, first I need to replace those fluids. And again, kind of like with hypovolemic, if I replace those fluids and my blood pressure is still low after, then I'm going to need to give vasopressors. One of the first things I need to do is to get cultures on this patient. And after I get the cultures, then I'm going to give antibiotics because that I need to fix the problem. I can treat the symptoms all day long, the vasodilation, the lack of fluids. But if I don't get to the bottom of that infection, this patient's not going to get better. And then I'm also going to treat the other symptoms they might have that can make it harder on their body, like a fever. That elevated temperature can utilize a lot of the oxygen supply. And so I need to try to do what I can to get the body where it's not having to work so hard to sustain its oxygen supply. So let's kind of talk about now general medications for shock, because I brought up some of these things like vasopressors, vasodilators, and things like that. Kind of look at it this way. If I need more resistance, like in other words, my SVR is low, or in other words, I am dilated. I need things like norepinephrine, phenylephrine, epinephrine, or vasopressin. You can kind of see a lot of these have the ephrin in them, or pressin, like it's pressing on your blood vessels. On the opposite end of the spectrum, if I am really, really, really restricted or constricted, if there's a lot of resistance, my SVR is high. I'm going to give things like vasodilators, like nitroglycerin or sodium nitroprusside. If the problem is my heart pump, or in other words, the muscle of my heart is not squeezing effectively, I need medications like dobutamine, dopamine, or milrinone. Those are positive inotropes that are going to help to increase that contractility. And then if I need more preload or I need more volume, I need to give fluid blood or albumin. And if I need less preload, I usually give diuretics. So let's kind of break each of these down. So vasopressors, these work on the blood vessels. They're going to increase my SVR. So in other words, if I'm vasodilated, I don't have enough vessel or blood vessel squeeze, I need more squeeze. I'm going to use these to press blood vessels and increase not only my SVR, but it's probably going to increase my MAP too, or my blood pressure. These need to be given through a central line because they're a vesicant. And one of them, the norepinephrine, it used to be called Levophed, leave them dead, because it would cause really, really bad, tissue death to the fingers and the toes. Because what happens with these medications when they're squeezing on your blood vessels is they really focus on the trying to get blood flow to the really important organs in the center of your body. So those tiny little blood vessels in your fingers and your hands, they get so constricted that a lot of times they completely lose blood flow. And so we really want to use the minimal amount of these as necessary to prevent these kind of complications. Of course, because there's vasoconstriction, it's going to cause, tachycardia and hypertension. And we need to monitor for dysrhythmias as well. And we have to do very good peripheral nerve vascular assessment, like I mentioned, to prevent them from having loss of cell tissue. And this happens mostly it's not anyone who's on this, it's usually when they're on it more long term. But you really need to keep a close eye on that for these patients. There's also vasodilators, and these also work on the blood vessels. These are going to do the opposite of what vasopressors are going to do, and they're going to dilate. They're going to open. So if I have too much resistance, too much pressure in my blood vessels, these are going to help to open and relax them. So this is going to decrease my SVR, make there less resistance, but it's also going to decrease my MAP. It can cause profound hypotension. The main one that we talked about, because nitroglycerin, it can be used sometime, but most often, if I really need a good vasodilator, I'm going to use nitroprusside. This is not for long-term therapy. There's actually some cyanide in this medication, and so if I'm not going to use this long-term because otherwise I have to monitor for cyanide toxicity with this medication, and it also needs to be protected from light, or I have to put a special bag on the outside of it that the pharmacy sends me that helps protect it so that the medication stays stable. Because in other words, if it's exposed to light, it can become ineffective. Then there's also inotropes. So when I say inotropes, you can have positive or negative inotropes. I'm talking about are positive inotropes. So think positive, like rah, rah, rah. They're going to support your heart to squeeze better and build up that muscle. These work specifically on the heart. They're going to increase my cardiac output. And by doing so, they're probably going to increase my MAP as well. These need to be given through a central line because they're also vesicants, and we have to watch that IV closely. There's dopamine and dobutamine, and then there's also milrinone. Sometimes, just to mention, these also are used in conjunction with vasopressors because sometimes you need help with your heart and your blood vessels. Um, as a whole for dopamine, I want to monitor their peripheral perfusion and make sure that they're getting effective flow because kind of like with the vasopressors, they can have kind of a similar issue. And then milrinone, actually, they have these cool little pumps that people can wear. So let's say that I'm waiting for a heart transplant and I need a positive inotrope to kind of squeeze until I can to kind of help with that contractility until I can get a heart transplant. Milrinone can be given through a pump, like kind of like an insulin pump at home, where they can kind of have this implantable pump where they don't have to constantly, be in the hospital on this medication to sustain them. Some other medications are going to be fluid, blood, and albumin. And again, these will increase your preload and increase your MAP. Keep in mind, albumin is a blood product, just like blood is. So we need to get consent. We always want to make sure the client gets fluids first. So always when you think fluids first. You always have to give fluids before giving any medications, like vasopressors. Because here's the thing: there's no point in giving me, vasopressors if I have no fluid to squeeze. I have to have something to squeeze in order for squeeze to be helpful. So you always have to start with fluids first, and then the squeeze. And then what do you call it? Of course, keep in mind that's for patients that need both of those things. So yes, so fluids. If the patient's missing fluids, you always have to replace those first, or blood if the blood's what they're missing, whatever is they're missing, and then you do the vasopressors. And that applies to hypovolemic and septic shock. Remember, in cardiogenic shock, they are fluid overloaded, so they do not need any more fluid. They need to get rid of fluid. They need the opposite here at the bottom. They need the diuretics. Getting to that, sorry, real quick before I get there, anytime I give anyone fluids, blood products, or albumin, I also want to monitor for overload. I can very easily overload someone, especially with like septic shock. These patients, they receive a lot of fluid. So I need to monitor closely for that. Or if I have a patient who has hypovolemic shock and they received a lot of blood products, I need to monitor for signs of massive transfusion reaction, like that they're extremely cold or having other bad reactions to that. So then diuretics are going to be the opposite. They're going to decrease the preload and the MAP. We need to monitor closely for fluid and electrolyte imbalances, especially the potassium, if you remember. Monitor kidney function because most diuretics can be hurtful to the kidneys. And then always want to check your blood pressure prior. Just keep in mind that diuretics are going to decrease your blood pressure. So if I already have a low blood pressure, it may not always be appropriate to give. So definitely going to need to monitor that closely. Most people don't think, hey, I'm getting rid of volume, or I'm getting rid of fluid, so my blood pressure is going to go down. But that's what happens when you get rid of fluid. So my overall, my role of the nurse in a patients with shock is going to be support their nutrition, give trickle feeds, advances tolerated, do daily weights, really support their nutrition because I know this might seem like, hey, well, that's not really a big deal. This person's dying, but this is really important as a whole because nutrition plays such a crucial role in these patients' healing. I want to do frequent assessments of tissue and organ perfusion. And, of course, to remind you, how do we assess for perfusion? We're going to do a very good peripheral neurovascular assessments, your 6Ps and 1C. We're also going to be looking at oxygen levels. We're going to be monitoring for, their respiratory status. We're going to be checking their tissue, their organ functions, like checking kidney function, liver function, and things like that as well, just to be trying to keep that steady perfusion. Um, and then, of course, monitoring their ABCs. I want to monitor and their level of consciousness, make sure that they have a patent airway. They may have tachypnea or an abnormal breathing pattern, so I need to watch and make sure their breathing is supported. They're in a comfortable position, they can breathe well, and also monitor those oxygen levels closely. Additionally, the patient often is going to have low blood pressure, so I need to monitor their vitals and watch those hemodynamics closely and make sure that I'm meeting whatever need it is that they have. And then, last but not least, strict I's and O's. So I need to monitor their fluid and electrolyte balance closely and their cardiac rhythm. A lot of the medications we give for shock and just the shock process itself can lend a person to get a dysrhythmia. So I just need to keep a close eye on that. Well, I hope you had fun learning about shock. Wasn't so bad, was it? Yeah, I know it always seems like it's going to be overwhelming. And then you're like, wow, this was really cool. I want to become a teacher like Professor Woodruff, right? Yeah, you want to do this too. It's going to be so much fun one day. Can't wait to work with you. Bye.